Alright, so hello class. I will be doing a lecture on the part 1 of neoplasia. So, what do you understand when you say it's neoplasia? Anong napupunta sa mind ninyo? Neoplasia. Okay, so it refers to a tumor, a neoplasm. It refers to a cancer, okay, a tumor. Okay? Pero alam naman natin when we were studying inflammation that a tumor, it does not necessarily mean cancer. Okay? It can be a swelling or an inflammation or a pamamaga. Okay? Cancer refers actually to all malignant tumors, no? The tumors that can spread. Although we're going to define it clearly later on. A crab is something that adheres to any part that it seizes upon in an obstinate manner. And this is characterized by the cancer. Didikit siya, it attaches itself to any tissue that it is close to, and it can cause inflammation there. It can injure that area there. Now, a neoplasm is an abnormal mass of tissue, the growth of which is autonomous and exceeds that of normal tissues. Okay, so yun ang problema no, sa neoplasm or sa tumor. They can outgrow all the normal tissues. So what does that mean? It will get all the nutrients intended for the normal tissues. Cell proliferation persists after cessation of the stimuli that evoked the change. Okay, even if you stop the stimulus, it will still proliferate. That's the problem with tumor. Now, how do we name or how do we uh, name tumors? You have proliferating two basic components of a tumor. You have the neoplastic cells constituting the parenchyma. I think I mentioned this one when we discussed tissues, no? And the supporting stroma or stroma, which is a connective tissue which contains the blood vessels, the connective tissue framework. Okay? So, mga nerves, blood vessels. So, if there is can't support, konti lang ang stroma, konti lang ang fibers, so it's a soft, fleshy tumor, malambot. But if there is too much abundant stroma, maraming fibers, it is now called dysplasia, and it is stony hard, matigas, and it is known as your serous tumor. Serous tumor. Now, to classify tumors, we use the term benign and malignant. We will discuss what is benign and what is malignant later on. But in the nomenclature, you have to classify if it's coming from what parenchymal cells. Remember when we were discussing mesoderm? Okay, mesoderm is coming from your mesenchymal. So these are connective tissue origin pag mesenchymal, di ba? So you have fibroma is the benign. It becomes fibrosarcoma if it's malignant. Notice that if it's mesenchymal, if it's malignant, you add the suffix sarcoma. Lipoma, benign, liposarcoma. Chondroma or cartilage, chondrosarcoma. However, osteoma is now osteogenic sarcoma. If it's naman yung blood vessels, endothelial and related tissues, no? So again, this is also coming from your mesenchymal. Remember, mesoderm ang endothelium and mesothelium. So blood vessels, hemangioma, angiosarcoma. Lymph vessels, lymphangioma, lymphangiosarcoma. Synovium or the synovial, wala siyang benign, diretso na siyang synovial sarcoma. Mesothelium, mesothelioma. Take note, mesothelium is mesothelioma but it belongs to the malignant type. Brain coverings, meningioma or invasive meningioma. Pag invasive meningioma, that is malignant. Wala siyang sarcoma. So these are the exemption to the rule, no? Mesothelioma, meningioma, walang sarcoma, pero they are classified as malignant mesenchymal cells. Pag hematopoietic leukemia, walang benign sa blood tumors. Lymphoid tissue, lymphomas, nandito siya agad sa uh, tawag dito, nandito siya agad sa malignant. Pag muscle, leiomyoma, leiomyosarcoma if it's smooth muscle, rhabdomyoma, teka, tanggalin ko na lang ito. Rhabdomyoma, rhabdomyosarcoma pag malignant. Pag striated or skeletal muscle. Pag tumor of epithelial origin, so kanina yung na-discuss natin mesenchymal, no? This time, epithelial. Pag epithelial, okay, instead na sarcoma ang suffix, it's carcinoma. Okay, so, stratified squamous, squamous cell papilloma. What is the malignant counterpart? Squamous cell carcinoma. Sa skin, tandaan sa skin or sa adnexa, wala pong benign, diretsong basal cell carcinoma. Epithelial lining of glands or ducts, you have adenoma, adenocarcinoma. Papilloma, papillary carcinoma. Cystadenoma, cystadenocarcinoma. Respiratory passages, no? Bronchial adenoma, bronchogenic carcinoma. Sa renal or sa kidney, tubular cell adenoma, renal cell carcinoma. Sa liver, liver cell adenoma, hepatocellular carcinoma. Sa urinary epithelium, take note, transitional, di ba? Transitional cell papilloma, transitional cell carcinoma. Placenta, H-mole or hyaditiform mole, benign. Choriocarcinoma, malignant. Sa testicle, sa mga lalaki, no, wala silang benign, seminoma is malignant. So this is an exemption. Embryonal carcinoma sa mga germ cell. Nebus or mole sa skin, benign yun, hindi yun cancer. Pero pag eto naging cancer, malignant melanoma. Ngayon, pinag-usapan natin kanina from one epithelial type, epithelium or mesenchymal. So, epithelium is ectoderm, mesenchymal or mesoderm. Kaya lang, there are certain carcinoma that are mixed. Hindi pwedeng epithelium lang, mesoderm lang, connective tissue lang. So, it can be a mix. Example, salivary glands. You will learn in your, anong subject yun? Sa mga dentistry student, you have this saan na natin naaral to? Oral anatomy, okay? About pleomorphic adenoma, and it is known to be mixed tumor of the salivary gland. It contains epidermis, epithelium, it contains connective tissue and muscle. Okay, so mixed siya. So, in salivary glands, benign is pleomorphic adenoma, malignant is malignant mixed tumor of the salivary gland origin. Renal or kidney, renal and large, mixed yan, no? Merong epithelium, merong connective tissue. Wilms tumor is the malignant. Wala po siyang counterpart na benign. More than one neoplastic cell type derived from more than one germ cell layer or teratogenous. Okay? Totipotential in gonads or embryonic rest. Since this is coming from more than one germ layer, mukhang ang tinamaan dito yung pinakaninunong cell. So, usually this happens in the reproductive organs like mature teratoma, immature teratoma. Mature is benign, immature is malignant. Dermoid cyst, teratocarcinoma is the malignant counterpart. So this is just naming carcinoma. So as a summary, if it's benign, check if it's coming from the connective tissue origin or mesenchymal. Pag mesenchymal, oma, then the counterpart is sarcoma. Pag epithelial, oma, the counterpart is carcinoma. Nagkakaiba lang, there are certain there's certain tumor that does not follow the rules, but there are few naman, so you can easily memorize them. So in benign tumors, oma plus cell of origin, fibroma, lipoma, angioma, mesenchymal ito kasi fibroma is fiber. So sa connective tissue yan. Lipoma, yung mga adipocyte natin is connective tissue yan. Angioma, blood vessels. Osteoma, bones. Leiomyoma, smooth muscles. Okay? Let me just show you this picture. This is a lump at the back of the neck of a person. They try to remove it, and it is like this, no? Okay. And then they do a microscopic examination of the tissue that was removed. Mukha siyang ano itsura niya? Do you see the adipose cells? Okay, this is actually your nucleus. This is the adipose. Nucleus, the adipose, nucleus, no? So this is your adipocyte. This is benign. If you notice, you can easily distinguish it almost similar to the normal adipose tissues. Okay? How about this? This is similar to the other, but this is the malignant counterpart. This is liposarcoma. Look at the appearance, mukhang patatas. Under the microscope, this is the appearance. Can you still recognize an adipose tissue here? Sa unang tingin, wala. Ito yung adipose, ito. So, that is one way to differentiate a benign from a malignant. This is malignant because it's difficult to distinguish from a normal adipose cell. Compared it to this one, almost similar. So benign is similar to the normal, malignant is far from the normal. Okay? Now, there are benign epithelial tumors with complex nomenclature. We have adenoma, they arise from glands or glandular pattern. Kung may gland sa loob, adenoma. Cystadenoma, adenomas producing large cystic masses, ovarian cystadenoma. Papilloma is with papillary structures, mukhang finger-like projection. And polyp, kung narinig nyo na ito, this is a tumor protruding from a mucosa into the lumen. Para siyang mushroom na tumubo sa lumen. So this is papilloma. Look, mukha siyang finger-like structure. Okay? Etong adenoma because they are glandular in pattern. At may cyst sa loob, may mga tubig-tubig. So cystadenoma ito. Okay. So for the malignant tumor, carcinomas from epithelial origin. Kaya nga, carcinoma ang suffix ng mga cells like renal cells, adenocarcinoma. So this is from the epithelial origin. Bronchogenic squamous cell carcinoma. This is epithelial in origin. Undifferentiated or poorly differentiated carcinoma. Again, this is epithelial. Pag sarcoma, galing to sa mesenchymal or connective tissue like fibrosarcoma, liposarcoma, leiomyosarcoma, pag smooth muscle, rhabdomyosarcoma, pag striated or skeletal muscle. The appearance of a bronchogenic squamous cell carcinoma, just to show you. Okay, ito yung appearance niya. Hindi mo na siya ma-differentiate sa normal, no, na epithelium ng bronchi. Okay, ito yung liposarcoma that I showed you earlier, showing the difference from a adipose or lipoma, no, lipoma and liposarcoma. Now, pag mixed tumor, kaya nasabi natin, ito po ay more than one germ layer. Pleomorphic adenoma of the salivary gland is the classic example. Meron siyang epithelium, meron siyang cartilage and bone. Kaya, mixture siya ng connective tissue at saka epithelial tissue. Meron pa siyang myoepithelial cells. Pag teratoma, okay, it's a various parenchymal cell type from more than one germ cell to another. It arises from totipotential cells. It is common from in the ovaries and the testes. Kasi nga, sila yung ninunong cell. So, malamang doon pa lang sila sa reproductive organ nagsimula. So, these are your teratoma. Ang teratoma mukhang balot. May hair, which is epithelium. This will become the bone. Merong muscles there. Merong fleshy doon na mukhang magiging brain. Okay? So, this is your teratoma. This is another picture of your teratoma. Okay? Look at it. No? May hair. So, epithelium. May, mukha siya talagang balot. Balot na balot ang itsura. Okay, so teratoma or multi-potential. Galing siya sa more than one germ layer. Now, let us differentiate a teratoma, a benign and malignant neoplasm. Okay, so characteristics of benign and malignant neoplasm. So we can distinguish based on the morphology and behavior using the four criteria. First is differentiation and anaplasia. Second is the rate of growth. Third is local invasion. Fourth is metastasis. So with exemption, there also exists a marked discrepancy between morphologic appearance and its behavior. So discuss natin yan mamaya. Let's start to define differentiation. When you say differentiation, it refers to the extent to which parenchymal cells resemble or comparable or resemble the normal cells. Kagaya na pinakita ko kanina. I showed you the picture of a benign and a malignant. Benign, near the appearance of a normal adipose cell. Malignant, far from the appearance of a normal adipose cell. But you have to check that it's not only morphology or appearance, but also via the function. Okay. Benign tumors are well differentiated. In general, are well differentiated, meaning they can easily be you can easily recognize them similar to a normal. Malignant, however, can be pwedeng pareho sila to undifferentiated. Now, better differentiation parallels with the function, comparable to the normal counterparts. So, kung nalilito ka na, kung well-differentiated siya, pero mukha naman siyang malignant, paano natin malalaman? Okay, so we base it now on the function. Well-differentiated squamous cell carcinoma elaborates keratin. Kasi 'di ba alam nyo, sa skin natin may nagpuproduce ng keratin to protect our skin from dehydration. Now, well-differentiated squamous cell carcinoma elaborates keratin. So pag well-differentiated daw, nagpuproduce pa rin ng keratin, nagagawa pa rin niya yung trabaho niya. Well-differentiated hemangiocholecarcinoma. Hemangiocholecarcinoma is a tumor of the gallbladder. They still produce bile. Kaya lahat ng well-differentiated, nagagawa pa rin nila ang trabaho nila. Kaya lang, merong kakaibang tumor na ginagawa niya kahit hindi niya trabaho. We call it your bronchogenic oat cell carcinoma. It synthesizes ectopic hormones. Gumagawa siya ng mga hormones na hindi naman niya trabaho like ACTH. Sino ba dapat gumagawa ng ACTH? Diba? Adrenocorticotropic hormone. Okay, yung mga adrenals natin. Parathyroid hormone, di ba yung parathyroid gland ang dapat nagpuproduce niyan? Insulin, di ba si beta islets of Langerhans, tsaka glucagon, si alpha islets of Langerhans. So all of this, may mga organs na specifically yun ang trabaho. Pero, cancer siya ng lungs, nagpuproduce siya ng mga hormones na ganon. So, this is a kakaibang tumor kasi hindi lang niya ginagawa yung masyado siyang masipag, ginagawa niya yung hindi niya trabaho. When you say anaplasia is to form backward, Okay? Lack of differentiation, it is, take note, the hallmark of transformation. And ano nakikita natin dito? There is nuclear and cellular pleomorphism, wide variation in the size and shape of cells and nuclei. Okay, there is nuclear and cellular pleomorphism. Morph is morphology. Pleo, iba-iba ang appearance. Wide variation in size and shape. Hyperchromatism, nagkakaroon ng dark staining, makapal yung staining. Okay? And NC ratio. Ito ang pinaka-importante. When you say NC ratio, it refers to the nuclear cytoplasmic ratio na ang ideal is 1 is to 4 and 1 is to 6. Ano ibig sabihin yan? Yung size ng nucleus is 1/4 the whole cell or 1/6 the whole cell. Hindi siya halos kasing laki ng, it's not almost similar to the size of the whole cell. So, if the nucleus, okay, let me see what I can use here. Wait. Oh, ito na lang. Okay. This picture. This is your hematopoiesis. Okay. And when you say anaplasia, you see immature cells in the blood. So what do I see in the blood? Instead that I see the normal RBC, I would see this type of RBC. Note the nucleus. What can you say about the nucleus? The nucleus is almost 1:1, almost occupying the whole cell. Because that indicates that there is anaplasia or to move backward. Okay? What can you see about the thickening of the chromatin? If you notice, no, kasi nucleus does not, RBC doesn't have nucleus. But if you go clearly, there's darkening of the inside. There is hyperchromatism, which is common in younger cells. If you see these cells in the blood, which is not supposed to be, then that is anaplasia. You see younger cells in the blood. If you remember, I made mention about shift to the left. Diba? You see lots of very young cells in the blood. That is a sign of leukemia. Okay? So, take note, the normal nuclear cytoplasm ratio is 1:4 to 1:6. Meaning, the nucleus is 1/4 to 1/6 the size of the whole cell. But what happened? Masyado ng napakalaki ng nucleus. And there is thickening of the chromatin materials. Okay? So, malignant tumors are invasive, infiltrating, and destroying the surrounding tissue. Wait po. Ano ba yung ano dito? I am looking for... Okay, so this is good evening class. This is evening because I'm doing the lecture during the night. So, let's start from the current slide. So, last meeting, we ended up in this slide and we said about anaplasia. No? One characteristic of tumors is that the characteristic of the cells are forming backwards. So, they look like the younger version of the cells. No? So, for example, like this one, no, instead that you see an RBC like this, you see lots of like this, the immature red blood cells. So if you see a lot of this, or like for example, these younger blast cells in the neutrophils are in the WBC series, you are considering tumor of the blood or leukemia. So one characteristic of tumor is they infiltrate, they invade other tissues. On this side is a benign tumor. Ito yung tumor na safer. It does not metastasize, or it does not go to another tissue because they are covered by a capsule. So they are encapsulated. And it's easier for the physician to, or the surgeon, to remove the tumor kasi nga isang capsule siya. So it's benign. The problem with malignant tumor is that sisiksik sila sa tissue. When they do that, what happened is they squeeze and insert themselves on the normal tissue, and when the surgeon operates on them, the surgeon has to remove a large portion of the tumor, including surrounding uninvolved tissues. So, in this case, malaki-laki yung natatanggal, no? And if that particular organ, for example, has a specific function, then mababawasan yung trabaho ng organ na yun. Now, next to the development of metastasis is invasiveness. Okay, it's the most reliable feature that differentiates a malignant from a benign tumor. Kung ang tumor is, it easily invades other organ, okay, then it is most likely malignant. Now, there's a term that they use, CIS, or carcinoma in situ. This displays a cytologic feature of malignancy without invasion of the basement membrane. So we studied in the epithelium that there is this is the epithelium, simple columnar. It has a free space and it is sitting on a basement membrane. If the tumor does not go beyond the basement membrane, it is called carcinoma in situ, which is actually good. Good yun. Kasi we know that underneath the basement membrane are your blood vessels. So if the tumor will scatter, it will metastasize, or it transfers to another organ, delikado if it passes through the blood vessels. Kasi pag nandoon na, wala na, lilipat na siya sa ibang lugar. Now, speaking of metastasis, this is the distant spread of tumor, and if it's present, it now tells us that that particular tumor is definitely malignant. Okay? So almost all malignant tumor have the capacity to metastasize or transfer to another place or distant spread. However, may mga tumor na even if they don't metastasize, they are already considered malignant. These are tumors of the brain, like your glial cells. Remember, we studied neurons and neuroglia. Neuroglia are actually the supporting cells of the brain. Pag tinamaan yun, automatic na that is a malignant tumor. What else? The skin, basal cells of the skin. Remember yung stratum natin, no? The stratum basale pababa, dermis, hypodermis. If the tumor is in those location, automatic. Even if it does not metastasize, it does not metastasize, those are actually considered malignant. Now, paano nga ba kumakalat ang tumor? No? So, there are three routes. First is via spread into the body cavities. So, for example, they were wondering bakit yung mga may sakit, may cancer sa tiyan, like sa colon, sa intestine, mabilis silang mamatay, no? Bakit? Kasi ang problema sa tiyan, marami siyang katabi. Okay? It has other organs beside it. So kung katabi mo, example, yung ovaries natin, nasa tiyan yun, no? Nasa tiyan. Ovary, nasa peritoneal cavity, sa abdomen. So, pag yung ovary, may tumor doon, madali siyang pupunta sa liver, pupunta siya sa colon, sa large intestine. So, ang dali lang niyang kumalat kasi iisang compound sila, kumbaga, no? Isang cavity sila, magkakasama sila doon. Another type of tumor, pseudomyxoma peritonei, is a mucus-secreting appendiceal. So, appendix naman ito, tumor siya, nakakalat na, it's like a gelatinous mass on your abdomen. No? So, yun ang problema. Number one, route for your metastasis is spreading into body cavities. So, kung isang cavity lang sila, they can easily seed the tumor to the other organs. Number two is via the lymphatics. No, we learned in our anatomy before that lymphatics absorb excess fluid in our body. So this circulates like your blood. So the problem, if the tumor goes to the lymphatics, it easily transfers to the different lymph nodes in the different parts of the body. A common example of a tumor that transfers via the lymphatics is the breast cancer. Si breast, no, pag when you examine if there's a tumor on the breast, usually commonly kakapain din nila yung kilikili. Kasi sa kilikili natin merong lymph nodes, no. If there's a tumor in the breast, kakapain din itong kilikili because most of the time the breast tumor can go to the lymphatics because it's very near, no. So yan. So there's a term here that they say skip metastasis, no. Sometimes uh, if the tumor goes to the lymphatics, it does not metastasize. It stays in the lymph nodes, no? Hindi nalilipat sa ibang organ. So that is called skip metastasis. Okay, so that happens in lymphatic route. Ang delikado sa lahat is yung kung if the tumor went to the blood. If the tumor went to the blood, it undergoes hematogenous spread. Common among sarcomas, yung mesenchymal or mesenchymal or connective tissue origin and renal carcinoma sa kidneys, no? Between a vein and an artery, usually what is more frequently invaded is the vein kasi mas manipis siya, thinner. Now, if the tumor goes to the blood, the two organs commonly to be the site of metastasis would be the lungs and the liver because we have both of them receive systemic and venous outflow. Remember naman, no, yung ating blood flow from the body goes up to the right atrium, right ventricle, pupunta sa lungs. Okay? From the stomach, laging dumadaan naman sa liver kasi may portal blood vessels doon. So these two organs are commonly the site of metastasis, no? Now, we go now to the term dysplasia. When you say dysplasia, disordered growth, magulong paglaki in Tagalog, no? So, when you notice the epithelium, uh, you, paano ba yun? May I have an eraser, please? Bakit nakaano ang eraser dito? Okay. Uh, let me just draw a new one. So this is the epithelium. We were taught that they are usually on this almost the same shape naman, no? Not actually, but almost the same. So what happens in dysplasia? If there's dysplasia, what happens? There is irregular shape of the epithelium. It looks like elongated. Sometimes it looks like cuboidal. And um, there, if you have dysplasia, there is loss of uniformity. So, iba-iba yung shape, no? Hindi na sila may squamous, may flat, may elongated, ganyan. So, it does not follow yung simple cuboidal, simple columnar already. What else? Tumor cells display total disarray of tissue architecture. There is loss of polarity. Di ba? You were taught that in histology that there are what you call gap junction. Gap or gap uh, junctions. No, so these are the ones that keeps the cells together. They attach the epithelium together. But if the cells lose polarity, they are scattered. No? Pwede silang they can be scattered from one another. They are separated from one another. Now, carcinoma in situ is a marked dysplastic change involving the entire thickness of the epithelium with the basement membrane not breached. Again, this is good. Why? Because you don't go to the blood vessels, which is beyond the basement membrane. Now, it's actually a pre-invasive neoplastic lesion. It can become cancer later on. However, not necessarily all dysplastic condition progress to cancer. Hindi naman lahat nagpo-progress to cancer. Pero pwede siyang mag-progress. Oh, that's the thing there. So mild to moderate changes that do not involve the entire thickness of the epithelium may be reversible. Ibig sabihin, pag reversible, pag naagapan naman, it can return to its normal. It cannot cause tumor or cancer. Now, what affects the growth of tumors? First, we note that most cancer grow rapidly. Okay. However, why is it that some are fast, some are slow? So usually benign tumors slowly grow over the years. What are the factors that affects the growth? Number one, hormone. If the tissue is dependent on hormone, like for example, the breast is dependent on estrogen, the prostate is dependent on um, the prostate is dependent on tawag nito um, testosterone. Eh, so yun. And the hormone is adequate, then the tumor growth grows very fast. Okay, so what I was saying a while ago is that um, uh, hormones are one factor that affects the growth of your tumor, like leiomyoma or myoma, no? It causes myoma of the uterus. This is a tumor of the uterus, no? Is estrogen dependent. If there are lots of estrogen, the growth of the tumor is faster. Same thing in the breast. Breast cancer is affected by estrogen. Okay. Now, there is the rapid growing cancer often contains several areas of ischemic necrosis, which I explain later. Growth fraction of tumor cells has a profound effect on the susceptibility to cancer chemotherapy. So, what fraction of the tumor cells uh, is usually attacked by anti-chemo drug in your pharmacology, no? So, there are anti-cancer agents. They have they attack a specific cycle in the development of your or in the mitotic stage of your tumor. For example, diba, there is, if you remember, there's a G1 phase, there's an S phase, and the G2 phase. Usually, most anti-cancer agent attacks the M phase, the mitotic, mitosis phase of your of your growth of your tumor. Now, this is what I'm mentioning a while ago. Um, Usually, benign tumors have a capsule. Ayan. So, once the doctor or the surgeon enucleates it, tanggalin niya yan, napakadali. There is easier enucleation. Now, uh, this is to explain that ischemic necrosis I was referring to a while ago. When you say angio, it refers to blood vessel. Genesis is formation of blood vessel. Now, when tumors are present, this can cause vascularization or angiogenesis, meaning the tumor will promote the formation of new blood vessels so that they will be provided with the nutrients because the blood supplies the nutrients, no, for the tissues and even for the tumors. Now, if, for example, the tumor rapidly grows, it can be very, very big that the number of blood vessels supplying it is not enough. And because of that, we have what you call as ischemic necrosis, meaning some part of the tumor does not have adequate blood supply and so they are lighter staining. Now, another as I said a while ago, hormones affect the growth of tumor, particularly the breast, the endometrium, or the lining of the uterus, which is affected by estrogen. Prostate is affected by your testosterone. Now, to manage these tumors caused by this one, you can do the following hormonal manipulation. Number one is orchiectomy. This is so funny because in med school before, our teacher asked what is orchiectomy, and if he said if appendectomy is surgical removal of the appendix, and uh, cholecystectomy is surgical removal of the gallbladder, what is orchiectomy? And one of my classmates said it is the surgical removal of the orchids. And everybody was laughing when my teacher explained that orchiectomy is the surgical removal of the testes to prevent prostatic cancer. Now, for the females, estrogen receptor, estrogen is the one causing the growth of the tumor in the breast. So, what the drug do, your tamoxifen is a drug used by your, it's a drug, and what it does is it uh, inhibits the receptor of your estrogen. It inhibits the receptor of your estrogen. And so, what happens? Uh, you're preventing the attachment of estrogen to the uh, to the receptor, and therefore the tumor will not grow. Okay, the tumor will not grow. So because of tamoxifen. Okay. Okay, so how is cancer form, or what is the carcinogenesis of cancer? Okay, so all of us have oncogenes. What are oncogenes? These are cancer causing genes. And what are proto-oncogenes? Proto-oncogenes are cellular genes that promote normal growth and differentiation. So that is present in our body. But as long as it's okay that that is present, as long as you have a very strong tumor suppressor gene. Okay, because this gene decreases formation of tumor by applying brakes to cellular proliferation. What are examples of tumor genes? You have RB gene, which is noted to be mutant in tumors, and P53 gene, which is the guardian of the genome, and it's noted that these two are mutated in tumors. So if the tumor suppressor genes are mutated, so they cannot function as brakes to cellular proliferation. That's when tumor happens. Now, the problem with oncoproteins is that uh, they are devoid of regulatory elements, so they can multiply as long as they want. They're very autonomous, and they do not depend on growth factor or external signals. They just grow continuously. That's the problem of oncoproteins. Now, others consider chromosomal abnormalities to be a cause of tumor. Like, for example, um, translocation. When you say translocation, there is a transfer of one part of the chromosome to another part. No? So, and example for that is your Philadelphia chromosome. Philadelphia chromosome, there is a transfer between chromosome 22 and 9. So nag-transfer sila, translocation in 9 and 22, and so that is seen in a disease called your chronic myelogenous leukemia. Now, another is Burkitt's lymphoma. In Burkitt's lymphoma naman, there is translocation between chromosomes 8 and 14. The other is deletion, may natanggal. So, in retinoblastoma, there is deletion of chromosome 13. In your Q is your long arm 14. Chromosome 13, long arm 14 is deleted. While in Wilms tumor, this is a cancer of your kidneys, there is deletion of chromosome 11, P, or long arm 13. Now, if there is translocation and deletion, there is also amplification or nadagdagan. There's addition. So this is seen in neuroblastoma. Now, other things that are considered in the uh, growth of your cancer would be geographical and environmental factors. For example, in Japan, the death rate for cancer of the stomach is 7 times to 8 times higher than the US. Why is that so? Well, because when you say environmental factors, no, these are factors that are affected by our not only what we get from the environment but also our vices or our food intake, no? And in Japan, you know that there is more cancer of the stomach because they like to eat sushi, which is raw. Okay? As compared to Americans, they love cook. Meron pa silang well done, mga medium rare, mga ganun sila no sa pag-orders nila ng pagkain. Meaning they are more of the cooked type. They don't like the raw. So that's why it's not common in America for stomach cancer. However, it's common in Japan. Another is that lung cancer is 2 times more common in the US like in Japan. Well, that is probably because there are lots of smokers in the US compared to Japan, or even higher in Belgium. Skin cancer, like melanoma, 6 times more frequent in New Zealand than Iceland. Well, if you analyze this one, in Iceland, there is no sun. And we all know that exposure to the sun, especially with our destroyed ozone layer, what happened, or the greenhouse effect, what happened is we are prone to the development of skin cancer, especially the Caucasians because they are very maputi, no? They're light-colored skin. Those who are darker are protected because of the presence of melanin. Now, there are also environmental factors that can cause cancer, like asbestos in the environment can lead to mesothelioma, is a lung cancer. Vinyl chloride can cause cancer of the liver, angiosarcoma of the liver. Beryllium, another lung cancer. Smoking has a lot of cancer. Can cause cancer of the mouth, the pharynx, the larynx, the lungs, the esophagus, the pancreas, and the bladder. So it's very wide range, no? The effect of smoking. So for all of you who are smoking there, please stop na while you're young, no? Alcohol and tobacco, when you are used to taking them together, no? Umiinom ka na, naninigarilyo ka pa, you expect tumor of the aero, respiratory, and digestive tract. Sexual practices like multiple sexual partner can lead to cervical cancer. That's why pap smear is being requested, no? Beta-naphthylamine can cause bladder cancer. Now, age. Well, age plays a major role in cancer. Most cancer develop later in life, greater than 55 years old. However, there are exemptions to the rule. There are tumors that may occur in 15 years old and below. Okay, so you have acute leukemia, neoplasm of the central nervous system, like neuroblastoma, Wilms tumor or cancer of the kidneys, retinoblastoma, rhabdomyosarcoma. All of them can happen in less than 15 years old. Heredity is very important. If one family member, a close relative has the tumor, most likely the other members of the family may have similar neoplasm. Like for example, retinoblastoma, cancer of the retina, is known to be autosomal dominant. So it namamana. You can get it from your parents, okay? And susceptibility to colonic polyposis, yung polyp, can lead to uh, cancer or colon cancer later in life. If you have watched, ano bang movie yun? Midnight Sun, I don't know if you watched that. No, I watched that with my daughters, and it's a story of a girl who does not go out of the house, especially when the sun is up, because the sun enhances the exposure to the sun can cause the proliferation of the tumor. This is actually XP or xeroderma pigmentosum. This is a chromosomal DNA instability syndrome, and usually again this is inherited. Okay? Acquired preneoplastic syndrome. So these are diseases that are can cause or a predisposing factor for the development of tumor because hyperplastic and dysplastic proliferation are fertile soil for the malignant transformation. For example, endometrial hyperplasia. So hyperplasia is increase in the number of cells, and endometrial cancer are related. So endometrial hyperplasia, there's association, may be a predisposing condition for endometrial carcinoma. Cervical dysplasia can lead to cervical cancer. Now, there are also non-neoplastic. They are not neoplastic in nature. There are other diseases, but they can lead to cancer. Example, the patient has already always been drinking. So, nasira yung liver, nag-shrink, but later on, it can develop to hepatocellular cancer. Atrophic gastritis. Gastritis involves the inflammation of the stomach. It can lead to stomach cancer later on. Chronic ulcerative colitis. Okay, so there are ulcer in your colon. It can lead to cancer of the colon. Leukoplakia of the genitalia and oral mucosa. There is whitish lesions on the oral cavity and in the genitalia. This can later on lead to squamous cell carcinoma. Now, even inflammatory disorders can lead to cancer, like ulcerative colitis. Okay, there is a colon infection, Crohn's disease, another infection, another disease of the small intestines. H. pylori gastritis. So H. pylori is a culprit in ulcer. Okay, pag sinabing gastritis class, it means gas-gas. Pag yung gas-gas, it becomes deeper, it now becomes ulcer. Okay? So minor yung gastritis, it becomes deeper, it becomes ulcer. Now, it's due to H. pylori bacteria. Now, viral hepatitis is, an example is hepatitis B. Hepatitis B can lead to tumor, or you call it hepatocellular carcinoma. Chronic pancreatitis can also lead to cancer later on. Now, why is that so? Why are these preneoplastic syndrome occurring? No? Why? Because of three proposed mechanisms. Cytokine production, di ba? Cytokine is present in inflammatory. Production, growth of transformed cells. So, because of the cytokine, this stimulates the growth of transformed cell. And this also increases the pool of tissue stem cell susceptible to mutagens. And because of that, no, because the stem cells now are susceptible to changes. So pwedeng mag-mutate yung stem cell. The ROS, kilala niyo naman si ROS, radical oxygen species, can produce genomic instability. Kaya nga sinasabi nila, if you take lots of antioxidant, it prevents cancer. No, because ROS can make the genome very unstable, and because of that, they mutate. And this, they say, is the cause of cancer. Now, one of your classmates was asking me, Does a benign tumor become malignant? Okay. Most benign neoplasm do not become cancerous. Most malignant tumors arise de novo. What does that mean? If you are destined to become malignant, you will start as malignant. From the start, malignant ka na. However, there are exemptions. Actually, very rare. There are only three. No? The villus adenoma of colon, 50%. This is adenoma, so this is benign. 50% have risk of developing adenocarcinoma. So 50%. Long-standing myoma, no, may tumubong bukol sa matres or sa uterus, has a rare chance of developing ito leiomyosarcoma. And pleomorphic adenoma is, if you remember, this is a mixed tumor, no? Meron siyang epithelial, meron siyang connective tissue component, has rare malignant transformation. So, there are actually very few, only three benign tumor that can become malignant. Otherwise, all the other tumor, talagang distinct na silang maging malignant from the start. No? Yun namang mga benign, kung benign talaga sila, distinct na silang benign talaga from the start. So, very rare po yung benign naging malignant. Now, grading and staging of cancer. So, narinig nyo siguro, anong stage siya? Anong grade siya? Okay. So, when you say grade and stage, they provide a semi-quantitative estimate of the gravity of the tumor. Both are valuable for prognostication and for planning therapy. However, they say that staging has more clinical value. So, what is grading? So, aralin muna natin si grading. Grading is based on the degree of differentiation and the number of mitosis. So we grade it as 1 using the Roman numeral 1, 2, 3, and 4 with increasing anaplasia. In general, high-grade tumor are more aggressive. So pag grade 4 daw, more aggressive, they become larger very fast, they multiply very fast. However, there are imperfections of grading. Different areas may show different degrees of differentiation. For example, okay, I will use this one, a pen. Okay, let me see, a red. Okay, for example, this is the tumor. Okay, says there different areas show different degrees of differentiation. So, pwedeng dito well differentiated, pwedeng dito poorly differentiated. So, iba-iba. So, ibig sabihin, if the sample of the specimen that was taken is only from here, then you say, oh, it's well differentiated, so it can be but benign. Pero actually, if you go around the tumor, what you see, there are also areas of poor differentiation. So, mahirap ito, no? The other one is the grade of the tumor may change as the tumor grows. So, if this is grade 1 now, it can be grade 4 the next month. Okay, so because of that, it's the most doctors or oncologists, we call doctor of for cancer patient, don't favor grading. So what they use is staging, which is more helpful. When you say staging, it refers to the tumor, T, the node, and metastasis. Okay, so you are looking for the tumor size in the tumor. So there are different classification. For example lang, no? Pag 0 to 1 millimeter in size, it is considered stage 1. Okay, for example. Although it's different for different tissues, ha? For example, 11 to 20 millimeters, it's called stage 2. So it depends. No? Now for node, it counts how many nodes are possible. For example, if T is your size, N1 is 1 node, N2 is 2 to 3 nodes. So may ganun silang classification. And metastasis, if there is an or other organ that was infected by the tumor, so we call that metastasis. So they say that this is, if there's no metastasis, 0. If there is a nearby In an organ, probably there's a measurement 0 to 5 centimeters away from the main organ, no? Away, there is metastasis. So you can M1, M2, M3 until and so on and so forth. Now, between the two, grading and staging, they find this more helpful because it will give you the size of the tumor, if there is node invasion, or if there is seeding somewhere else, no? So, mas gusto nila ito na classification comparing it to the grading na iba-iba per location, no? Now, how do we diagnose cancer? So, what we do is if they operate on a patient, they get a sample of a specimen from the body and they submit it. No, it's important for medtechs to check on the to make sure that when you receive the specimen, all important data are present, like the name, uh, the ward, how old is the patient, etc. There should be adequate tissue preservation and sampling. We were taught how do you preserve tissues? No, always that if it's a specimen from a living person, no, you have to place it in a fixative, which is 10% formalin. Why is 10% formalin? It was studied that this particular solution can maintain the normal or the uh, normal architecture or appearance of the tissue for several period of time, even if it's removed from the body. So the appearance is almost similar to that of a living body. Okay, so this is a preservative, 10% formalin. Now, you can also do some frozen section exam to detect cell surface receptor. Now, another is they aspirate using a needle. I don't know if you have seen this one, or like this one, needle aspiration biopsy. Or this one, the breast, no? They do needle aspiration. And they're going to get a sample, send that sample to the laboratory for processing. Now, another is to get a pap smear. So, pap smear is Papa Nicolau smear. It was discovered by the one who discovered it is Mr. Papa Nicolau. And so it usually examines cells that are shed off. It is used for the diagnosis of carcinoma in situ and invasive cancer of the cervix or the lower portion of the uterus. But you can also use it for the stomach, for the bronchus and the urinary bladder. However, this is not commonly used, no, because there are other better parameters or better ways of checking on the tumor aside from getting a sample and do a pap smear, no? Kagaya sa stomach, pwede silang makita sa endoscopy. Sisilipin lang, they can see if there's a tumor inside, no? Same with bronchus, no? Sa airways, we have bronchoscopy. Sa urinary bladder, they prefer to insert they can also do they insert a needle and they're going to get a sample. And usually there are other means, but you can use pap smear for this, but it's not just very commonly used. What is more commonly used for pap smear is for cervical. Ito lang ang mas common ngayon, no? To check for cancer of the cervix, because cervical cancer in the Philippines is the number one cause of mortality among women. Now, how do they do the pap smear collection? No, you do the lithotomy position. No, they're going to insert this specimen. See this one, this speculum on the vagina, and they're going to swab there in the cervix. So this is the uterus. This is the lower portion, which is the cervix. Magsaswab sila doon. And then they place it on the slide and stain it for pap smear interpretation. For those who has warts, these are warts on the cervix, they will have to scrape this one and send it for biopsy. So what do you see in a normal cervix? Ganito, squamous cell. Of course, the nucleus is there. It's in the middle. And usually, there are chromatins pero hindi naman, it's lighter stain, so it's not that much hyperchromatic or maraming chromatin. You notice that the cell of the nucleus is 1/4 to 1/6 of the whole cell. Okay? There are, wala yung ano. So this is the normal, no? But once the nucleus becomes very large, like this one, ganito, tignan nyo to. Look at this particular cell. Oh, ayan, no? Meron ka nakitang napakalaking nucleus, very small cytoplasm, then you can start interpreting it as atypical. So if the doctor is going to count everything, it's mostly like that, then it will be reported as uh, there are atypical cells. So that is a screening now for cervical cancer. Okay, so they have to undergo a lot other tests now that this patient is having possibly having cervical cancer. Okay, so there. Now, aside from pap smear, we also have immunocytochemistry. Immuno is involving antigen antibody. Immuno, so antibody reveals fluorescent labels generation of colored products. So there is a they add a color to the to the cell so that you can easily identify them. DNA probe analysis involves the use of diagnosis for use in the diagnosis of lymphoids, so yung mga tumor in the lymphatic system, and with rearrangement of T and B cell antigen receptor genes. So lymphoid neoplasm, you use DNA probe analysis. How about DNA flow cytometry? It's a very good test because it measures the actual amount of DNA in the tumor cell. If there is more DNA, meaning the tumor cell can easily multiply kasi marami siyang DNA. But if there is less DNA, then it does not multiply very fast. Others, which are more common, the tumor markers. They use body fluids like blood. The most common is blood. And it is used to determine, it is number one, it helps in the diagnosis of the disease. And number two, it helps in the response of the patient to therapy. So example, ay naku, wrong spelling ka pa. Carcinoembryonic antigen. Carcinoembryonic antigen is to estimate any colorectal cancer. So, may cancer ka ba sa large intestine, cancer sa rectum, you check on that by checking your CEA. So, if the CEA level in the blood is elevated, then you might be considering colorectal cancer. However, ang problema sa CEA is it's also elevated in alcoholic cirrhosis, in hepatitis, and ulcerative colitis. So it's not only cancer that will elevate CEA, it's also other inflammatory diseases. So that should be considered in the assessment. Another tumor marker is alpha-fetoprotein, which is taken from the fetal yolk sac. Usually it is elevated in liver cancer and testicular germ cell tumor. And it is also slightly elevated in cirrhosis and hepatitis. It's a very good, it's useful to indicate the presence of liver or testicular cancer. And also, for example, they're already diagnosed. Now they want to check if the patient is responding to therapy or nag-recur ba yung sakit. Okay? So, for example, biglang tumaas ulit, no? Nag-normal na yung kwan because you already are treating the patient. Suddenly, it rises up again, then it indicates that there is recurrence. Bumalik ulit yung tumor or probably the therapy kulang pa. Kasi after they remove a tumor, you can also undergo chemotherapy, taking in of drugs and radiation. Baka the treatment therapy is not enough. That's why the tumors are the tumor marker, because the tumor markers are still elevated. Yan. Now, another is the prostatic acid phosphatase. No, this is measured again in the blood, and it indicates that you have an invasive prostatic cancer, meaning nagmetastasize na ang prostatic cancer. What is more commonly used today is your prostate-specific antigen, which is a screening test for prostatic cancer. If the normal value is less than 4 nanograms per deciliter. So if you have less than 4 nanograms, for example, 1, 2, it's normal. But if it's more than that, okay, it means that you you have to undergo a lot other tests because you might have prostatic cancer. So that's the end class of our lecture for neoplasm. I hope you learned something from this topic, and this is actually the end of our uh, the end of the midterm. So this is where your exam for the midterm will end.